This lecture is about the female genitals or genitalia. I suggest we first have a quick look at the basic anatomical words. We will also focus on the main gynecological symptoms, and we will review the questions you should ask a patient who presents with a gynecological complaint before we pass on to the physical examination itself. We will then focus on the main diagnostic tools and treatment options. The vulva comprises the entrance to the vagina and the urethra. The structures which surround them are called the clitoris, labia minora, and fourchette, and the encircling labia majora and perineum. The uterus is connected to the cervix or neck. The peritoneum is draped over it. The valley so formed between it and the rectum is the rectal vaginal pouch or pouch of Douglas, and the fold of peritoneum in which the fallopian tubes lie is known as the broad ligament. Now let's focus on the main complaints, that is to say the reasons why a patient would consult her GP or her gynecologist. Among these symptoms, let's name pelvic pain, vaginal discharge or leukorrhea, genital itching and burning, bleeding between periods or metrorrhagia, heavy periods or menorrhagia, painful periods or dysmenorrhea, breast pain and lumps, discharge from the nipples. Now let's have a look at the main gynecological diseases. The second most common cause of discharge is thrush or candida. Benign smooth muscle tumors of the uterus are called fibroids. A change of mood before periods is called PMS, premenstrual syndrome. Infection of the fallopian tubes, also called uterine tubes, is called salpingoitis. Now let's focus on history taking. One of the first pieces of information you should elicit when interviewing your patient is her menstrual history. Questions like, when was your last period? Was the last period normal? How many days do you bleed? How many days are there between your periods? Are your periods regular? Are your periods heavy? Are there clots or floods? How many pads or tampons do you need? Are your periods painful? Have you noticed any bleeding between your periods? Then you may want to pass on to the obstetric history. Let's have a look at the questions. Do you have children? How many? For each pregnancy. Antenatal problems. around delivery, like was it a vaginal delivery, forceps delivery, vacuum delivery? Was it a C-section? You may want to know more about the outcome, like stillbirth, birth defects, twins, etc. You may want to know more about the weight of the babies, the puerperium, which is a period of 6 weeks which follows immediately after the birth of a child, during which the mother's sexual organs recover from childbirth. You may want to know more about terminations of pregnancy, like when, why, how. Was it suction aspiration, dilatation and evacuation, abortifacient drugs? You may want to know more about miscarriages. Then you may want to focus on the breast. In which case, your questions are going to be: did you breastfeed or bottle feed? Do you practice self-palpation? Have you noticed any lumps? Have you noticed any change in the size and color of your nipples or tits? Do you feel any pain in one or both of your breasts? This leads us to have a quick look through the patient's terminology, which you will need to understand if you want to avoid any misunderstanding. There are many ways of talking about periods. Patients might use the words monthlies, time of the month, being on, have a visit from Aunt Flo, have the painters in, etc. To refer to her vagina, a patient may use the expressions down below, private part, fanny, pussy, birth canal, slit from bottom. The word clitoris can be abbreviated in clit. The labia can be referred to as flaps. The uterus as the womb, which is of Germanic origin. Menorrhagia can be referred to as flooding. When a patient talks about the change, she means her menopause. Your patient may ask for a clear blue. She means a pregnancy test. Another way of saying that a woman is expecting a baby is to say she has a bun in the oven. Your next questions are probably going to be around sex and contraception. Let's see what they are. Are you sexually active? Do you use any contraception? Like the pill, a coil, or intrauterine contraceptive device, sponge, spermicides, condom, diaphragm, behavioral methods such as withdrawal method, emergency contraception such as the morning after pill. Then you would ask about infertility problems if there are some. Have you had any problem conceiving? Some infertility treatments or alternative ways of conceiving, such as in vitro fertilization, intrauterine insemination, gamete intrafallopian transfer or gift. Then you would probably inquire about STDs, that is to say, sexually transmitted diseases. Have you had any STDs, such as chlamydia, HPV, syphilis, gonorrhea, hepatitis B or C, herpes, or AIDS. Then you would need to know if the patient has had her routine checkups. Do you have your routine checkups? Such as cervical smear or pap smear and breast screening. Now, let's review the main steps of the physical examination. To perform a physical, you will need an examining table with stirrups, a speculum, lubricating jelly, and gloves. For the pelvic examination, the patient lies supine or on her side on an examination table with her legs in stirrups and is usually draped. In the US, a chaperone is usually required, particularly when the examiner is a male, and may also provide assistance. Let's pass on to inspection. The pubic area and hair are inspected for lesions, folliculitis, and lice. The perineum is inspected for redness, swelling, abnormal pigmentation, and lesions. You should check the vaginal opening for signs of pelvic relaxation. During the speculum examination, the speculum is inserted to visualize the cervix. During the bimanual examination, the index and middle fingers of the dominant hand are inserted into the vagina just below the cervix. The other hand is placed just above the pubis symphysis and gently presses down to determine the size, position, and consistency of the uterus and if possible, the ovaries. You should end the physical with examination of both breasts. Now, let's review common diagnostic tools. Obviously, testing is guided by the symptoms present. In pap testing or pap smear, specimens of cervical cells taken from the pap test are examined for signs of cervical cancer. The examination may also detect uterine cancer and human papillomavirus. Microscopic examination of vaginal secretions helps identify vaginal infections. In microbiologic testing, culture or molecular methods are used to analyze specimens for specific STD organisms if patients have symptoms or risk factors. Bedside inspection of a cervical mucus specimen by a trained examiner can provide information about the menstrual cycle and hormone states. Imaging of suspected masses and other lesions usually involves ultrasonography, which may be done in the office. Both transvaginal and transabdominal probes are used. MRI is specific, but very expensive. CT is usually less desirable because it's somewhat less accurate, involves significant radiation exposure, and often requires a radio-opaque agent. Laparoscopy is a surgical procedure which can detect structural abnormalities too small to be detected by imaging, as well as abnormalities on the surfaces of internal organs. It's also used to sample tissue. Endometrial aspiration is a procedure done if women over 35 have unexplained vaginal bleeding. Now, let's have a look at the main surgical treatment options. An operation to remove fibroids while preserving the uterus is called myomectomy. Removal of the uterus is called hysterectomy. Repair of uterine prolapse by amputating the cervix is called Manchester repair. Dilation of the cervix to scrape the endometrium for histology is called dilation or dilatation and curettage. Thank you for your attention.